I'm Dr. Sabrina Siegel with the Neuroscience Education Institute, and twice a month I sit down with a renowned mental health care expert to discuss breakthroughs and best practices for treating patients with mental illness.
This is Psychosis and Medical Management Recap. Let's start with a question. What is the most common form of hallucination in Parkinson's disease psychosis? Is it 1, auditory, 2, olfactory, 3, tactile, or 4, visual? So, about half the patients have hallucinations. Parkinson's disease with no psychosis. Of the hallucinations, you can see 62.5% are visual. So the vast majority are visual. Typically what happens with these is you get this sort of strange illusion, which is a misperception of something. You know, you see a tie on the bed, you think it's a snake, that kind of thing. And passage phenomenon, this is the sense that somebody's moving, somebody's there, and that sort of starts initially, and then it eventually evolves into full-blown, very well-defined visual hallucinations. As far as the clinical symptoms, typically years before non-motor symptoms start, and constipation is actually the first one, and we think the alpha-synucleotides are actually starting in the gut. Also, you get REM sleep disorder, where people start having the inability to suppress their motor movements during REM sleep. Sometimes you can even get sleepiness, and you can lose your sense of smell, and you can get depression. All those can happen before you see the first whiff of any motor symptoms. All right, next. In pseudobulbar affect, what brain region plays a much greater role than previously recognized? Number 1, the brainstem. Number 2, the cerebellum. Number 3, the motor cortex. Correct answer is the motor cortex. So here we have what's going on. We've got, basically from pseudobulbar affect, is a problem with top-down regulation of emotional expression. You can see we go through the brainstem, the pons, it's the corticopontocerebellar circuit is disrupted. The cerebellum, we always think of as coordinating motor movements. Well, it also coordinates emotional motor movements, the emotional expression of emotion. The motor expression, obviously you have muscles that make you smile, you have muscles that make you frown and cry. So there we go, the cerebellum's our friend. Emotionally congruent response scaled and produced by the cerebellum, very nice. So disruption of this circuit impairs cerebellar modulation of emotional expression. Okay, and we talked all about this, granule cells, parallel fibers, Purkinje cells, cerebellar nuclei, and then Golgi cells. And it's not hard to disrupt this with all kinds of different neurologic insults to the brain. All right, next. Several potential antipsychotics in development have primary mechanisms outside of dopamine D2 actions. These include dopamine 1 receptor modulation, serotonin 2A receptor modulation, phosphodiesterase 10 inhibition. So the correct answer, of course, is all 3 of those. So beyond dopamine 2 antipsychotics in development, we've got the 35-700, which is predominantly D1, so that's D1 and high 5-HT2A. Lumateperone, which has, as you can see, all of these very interesting mechanisms, including very high affinity for 5-HT2A. Also remember, that's the one that has presynaptic partial agonism and postsynaptic antagonism of dopamine receptors, the D2 receptor. And that allows you, by doing that, you're turning down the release of dopamine, so you don't have to have as much blockade postsynaptically, which means less of the side effects that are associated with postsynaptic D2 blockade, like hyperprolactinemia and EPS, for instance. And then 1167 inhibits phosphodiesterase 10 enzyme. I had to look this up, but sildenafil, Viagra, is a phosphodiesterase inhibitor, but it inhibits PDE5, so that's a little different. That's peripheral. All right, next. In patients with non-alcoholic fatty liver disease, altered drug metabolism may be seen for patients taking medications that affect which CYP enzyme? CYP450, 1A2, 2D6, or 3A4? All right, well, 2D6 and 3A4 are the most common enzymes that metabolize medications, but 1A2 is the one that's involved here. So let's see if we can learn something here. So non-alcoholic fatty liver disease starts with asymptomatic steatosis, which is fattiness in the liver. Hepatic triglyceride accumulation greater than 5% of weight eventually evolves into NASH, which is non-alcoholic steatohepatitis. You see steatosis, lobular inflammation, and hepatocellular damage. It requires a second insult in the form of oxidative and metabolic stresses combined with inflammatory cytokine dysregulation, resulting in hepatocyte death, further inflammatory response, and fibrosis, which eventually progresses to cirrhosis when you've got a lot of fibrosis. But the impact on drug metabolism, expression is unchanged with 3A4. In one study, a decreasing trend, insignificant, was seen. So really no significant effect on 3A4. 2D6, no significant effect. 1A2, decreased activity without cirrhosis in animal and human studies. So 1A2 is the correct answer. All right. In non-cirrhotic patients with liver disease, are there significant alterations in drug pharmacokinetics in general? Correct answer is no. So non-cirrhotic patients with liver disease, hepatic disease without cirrhosis does not result in significant alterations in drug pharmacokinetics. Significantly impaired hepatic elimination only when cirrhosis is present. That's death of hepatocytes and fibrosis. Decreased 1A2 activity may be one exception in certain patients. All right, next. Incident rates of akathisia appear lowest for which atypical antipsychotics? Is it the partial agonist group? Is it acenapine, lurasidone, and ziprasidone? Or is it clozapine, iloperidone, and quetiapine? Correct answer is clozapine, iloperidone, and quetiapine. Aripiprazole can cause significant akathisia. It turns out that the partial agonists have to have very high affinity for the D2 receptor. They have clearly a risk for tardive dyskinesia. I've seen several cases on aripiprazole. Not sure yet about Brex and cariprazine. Cariprazine has the D3 mechanism, which might have something to do with it, but those drugs can definitely cause tardive dyskinesia. And one of the risk factors for tardive dyskinesia is the potency of binding to the D2 receptor, and aripiprazole binds incredibly tightly. Partial agonists have to bind tightly. They've got to compete with dopamine. So akathisia rates, the lowest is iloperidone, actually. If you look at iloperidone, it's 1 to 2%. Clozapine is 3%. Quetiapine is 1 to 4%. So the lowest is iloperidone. Trivia, who's the first author of the second pivotal trial that got iloperidone FDA approved? Me. Nobody cares because nobody uses the drug. I wish they did. It's a great drug. Very low risk of akathisia. Anyway, enough about me. Let's talk about me. Anticholinergic medications are an appropriate management strategy for, number 1, akathisia, number 2, drug-induced Parkinsonism, number 3, tardive dyskinesia. Correct answer is drug-induced Parkinsonism. But remember, these drugs are poisons. They are contraindicated in tardive dyskinesia. All right, treatment strategies for akathisia. Now, I also want to talk a little bit about the pathology of akathisia. Dr. Stahl actually wrote an article on this in CNS Spectrums about 2 years ago. It was a brainstorms. Turns out we do know a little bit about the pathology of akathisia. Now, just like dopamine and acetylcholine are on a seesaw balance, right? So this is going to be how we get Parkinsonism. Why do we use anticholinergic medications to treat Parkinsonism? Because if you block dopamine, let's say this is dopamine. Dopamine goes down, but acetylcholine goes up because they're on a balancing act. So we use anticholinergics to bring this down. Well, it turns out there's the same kind of seesaw in the basal ganglia, in the striatum, for dopamine and norepinephrine. If you block dopamine, the norepinephrine goes up. That's why we use beta blockers, which are blocking norepinephrine. They're beta norepinephrine receptors. Boom, we get it back into balance. Anticholinergics do not seem to work for akathisia because it's not an acetylcholine. It's a norepinephrine imbalance with dopamine. So benzos can help. Centrally acting beta blockers really is the treatment of choice. Mirtazapine also very reasonable choice.
This podcast was brought to you by the 15th Annual NEI Congress, a psychopharmacology conference that allows clinicians to improve their patient outcomes and earn CME credits. For additional information, see the link in the podcast description.